Welcome to The Explainer. Today, we are treating the human heart exactly like a high-stakes electrical grid to master first-principle electrophysiology and emergency interventions. I am so pumped to guide you through this because honestly, once you stop just memorizing patterns and actually start understanding the underlying physics of the heart, everything just clicks. We aren't just staring at squiggly lines on paper today. We are decoding real-time wiring degradation, severe circuit overloads, and complete structural grid collapses. Let's get into it. Here is our clinical triage board for today. We've got the decremental failure fork, the repolarization embargo, ischemic vector mapping, and finally, a mandatory validation drill.
Starting right off with Section 1, the decremental failure fork.
Okay, we've really got to grasp the first principle physics here. The AV node, sitting high up in the grid, fails gracefully using what we call decremental conduction. Think of it like a tired runner, right? It gradually slows down before taking a well-deserved break, which actually protects the ventricles below from being totally bombarded. But the His-Purkinje system down below, it uses an all-or-none mechanism. It doesn't get tired, it just rage quits. It completely snaps and fails without a single warning.
And that contrast is incredibly vital to see. With an internodal block, Mobitz type I or Wenckebach, you get this progressive PR delay. Watch how the gap between the P wave and the QRS just gets longer and longer until, boom, a beat is dropped. But then you have Mobitz type 2. Here, the PR interval is perfectly constant right up until an abrupt dropped QRS. That constant interval is the dead giveaway of a highly dangerous infranodal block in the His-Purkinje system. There's zero warning, meaning a much higher risk of plunging straight into a complete lethal heart block.
Welcome to the judge's bench. It's wild because these blocks react paradoxically to our interventions based purely on their anatomy. Say you push atropine, it speeds up the sinus rate. For a Mobitz I patient, great, the AV node speeds up and conduction improves. But give atropine to a Mobitz II patient, oh man, you're bombarding that already broken His-Purkinje system with rapid-fire signals. You'll actually worsen the conduction and drop more beats. On the flip side, vagal maneuvers like carotid massage slow the AV node down. For Mobitz II, slowing that upper rate gives the lower His-Purkinje system a much-needed second to recover, paradoxically improving the ratio. It's literally all about location. On the clinical floor, you're going to be handed a ton of distractors. I call this Step 2 noise. Things like age-related degenerative changes, or maybe the patient happens to be on a mild dose of digoxin. You have to actively filter that out. Train your eyes to look straight past that noise and hunt down those rigid, constant PR intervals that scream acute structural block, because that is the patient who needs immediate pacing.
Moving into Section 2, the repolarization embargo.
Let's escalate from wiring degradation to a full-blown circuit overload. Here is how this cascade builds. Certain meds or electrolyte imbalances block the delayed rectifier potassium channels, the IKR current. Without potassium leaving the cell efficiently, phase 3 of the action potential just drags on. We see this as a prolonged QT interval. Now, stuck in this vulnerable electrical embargo, voltage-gated calcium channels mistakenly reactivate way too early. We call these early after depolarizations, or EADs. And these rogue little sparks, they ignite massive chaotic reentry circuits. The result is a rhythm that forces split-second hemodynamic decisions. It's torsades de points. The rhythm is literally twisting, continuously rotating around the isoelectric line. The QRS complexes get massive, then tiny, then massive again, as if the electrical axis is physically spinning around the heart. It's the direct, terrifying result of those rogue calcium sparks we just talked about. It's a severe circuit overload and a massive medical emergency because it loves to degenerate straight into fatal ventricular fibrillation. And your intervention urgency ramps up incredibly fast here, based on hemodynamics. If they have ventricular tachycardia, but their blood pressure is stable, say above 90/60, you've got a second to breathe. You hang an IV infusion of amiodarone or lidocaine, but if they're in torsades, they are unstable. You push IV magnesium, absolutely, but you must immediately perform synchronized cardioversion. Now, what if they lose the pulse entirely? The grid has officially collapsed. You skip the drugs, skip the syncing, and immediately reach for the lightning, asynchronous high-energy defibrillation.
Section 3, ischemic vector mapping.
We have to remember that a structural grid collapse isn't just a static picture, it's a moving chronological timeline. Within minutes of a clot forming, T waves get hyperacute and massive due to altered repolarization kinetics. Give it a few hours and you enter the injury phase. This is where the ST segment physically elevates and the lead's staring right at the infarct.
And finally, as that vector solidifies, you get the reciprocal phase, where you see ST depression on the exact opposite side of the heart.
It really helps to visualize this in 3D. A massive anterior injury creates transmural elevations right in the front of the heart. But if you have an inferior injury, damage at the bottom of the heart, and you look at it from the high lateral perspective, you are going to see an anatomically opposite shadow. You see reciprocal ST depression. It's literally the exact same fire, you're just viewing it from the opposite side of the room.
Memorizing this exact grid is like having a cheat code. It lets you instantly pinpoint the failing artery just by mapping the current. V1 through V4, that's the left anterior descending. Lateral leads point to the circumflex. Inferior leads flag the right coronary artery. And if you catch ST depression in those front V1 to V3 leads, do not get fooled. That's a reciprocal shadow of the posterior descending artery failing way in the back. You map the vector, you find the clot.
All right, section 4. Let's run a mandatory validation drill to pull this all together.
Picture this, a 54-year-old female taking ciprofloxacin for recurrent UTIs suddenly faints. She hits the monitor and shows a rapid, twisting tachyarrhythmia, and her blood pressure tanks to 74/40. Now, every single detail matters here. Cipro isn't just an antibiotic in this context, it's a critical piece of the electrophysiology puzzle.
Let's reorder this chaos into a real-world timeline. The Cipro triggered a potassium channel blockade that dragged out her repolarization phase, lengthening her QT interval. Those premature calcium sparks we talked about, the EADs, fired off and sent her straight into Torsades the points. And because her ventricles are trapped in this chaotic, twisting loop, they aren't filling with blood. Boom, her pressure bottoms out at 74/40. She is acutely unstable.
Now quickly think back to our very first vignette with the 72-year-old male. He had a constant PR interval with abruptly dropped beats. Classic Mobitz type 2, right? Because his failure was isolated to those rigid His-Purkinje fibers. Applying carotid massage slowed down his AV node. It actually put the brakes on the upper system, which gave his broken lower system a chance to catch its breath, temporarily restoring a 1-to-1 conduction ratio.
Which brings us right back to our 54-year-old female for one final critical decision. Her pressure has plummeted to 74/40. She has a pulse, but she is highly unstable. What is the single most vital move to save her life right now? Do you calmly hang an IV amiodarone drip, or do you reach for the pads for synchronized cardioversion? Once you truly understand the physics of our failing grid, the answer is undeniably clear. I'll let you make the final call. Thanks for hanging out with me for this explainer. Keep mapping those vectors, and I'll catch you next time.